The Dartmouth Atlas has been a familiar part of the American health policy landscape since the mid-1990s. The Atlas monitors healthcare utilization and outcomes in 306 hospital referral regions across the United States. I'm Gil Welch, and I'm here to interview my boss for the past 2 decades, Jack Wennberg. And my goal is to communicate Jack's quest to explore the epidemiology of American medical care, how medical practice differs in different geographic regions. It's an intriguing story, one that starts in Vermont in the mid-1960s and is still relevant today as the Dartmouth Atlas continues to monitor what is actually happening to healthcare throughout the United States. Chapter 1, Vermont Beginnings. Our story begins with Lyndon Baines Johnson, the 36th President of the United States, 1963 to 1969. And it's fair to say President Johnson has a mixed record. His name is inexorably linked to the Vietnam War. He ordered the massive escalation of troops in Vietnam and ordered the bombing of Hanoi. At the same time, he's responsible for the Great Society programs, the War on Poverty, the Civil Rights Act, and Medicare and Medicaid. He also started another program called the Regional Medical Program. Jack, you were director of the Vermont Regional Medical Program, a program intended to bring the benefits of modern medicine to all parts of the country through regionalization. Now, you had just finished your residency in internal medicine. You were interested in nephrology. You were probably looking at distal tubules and glomerular filtration rates and all this stuff. What prepared you to be director of the Vermont Regional Medical Program?
Well, a lot of my friends would say not very much,
Okay.
but I can start at least trying to remember. Basically, not only did I do clinical medicine and epidemiology, but I also spent quite a bit of time in the School of Public Health and over at the Homewood campus doing sociology. So I had a broad interest not only in medical care, but also in the social systems which surround it and frankly, how things work in medicine.
And you all often mentioned Carr White as being an important person in your life.
Carr White was a really important person for 2 reasons. One is he preceded me when I came to Vermont and laid a lot of the groundwork for the work that we additionally did. But also, he was a very interesting acerbic skeptic about healthcare and a very good researcher and in quantitative methods and just was kind of an inspiring guy.
And he had a population view, didn't he?
Absolutely. The focus of the whole School of Public Health was that healthcare takes place in geography and in regions. It has to deal with the health of the population. It's not just a matter of who comes to the doctor's office.
So what did you do when you got to Vermont?
Well, first thing you ought to remember is that we had a very nice budget.
Oh, that's good.
And I walked up there without any previous experience in raising money, and because I was director, I inherited a budget which I think was about $300,000 a year.
Which was a lot in the mid-60s.
A lot of money, a lot of money. And so being quantitatively oriented and looking at populations, one of the things that we just quite naturally did was to try to set out and design a methodology for measuring healthcare throughout the region on a population basis.
Okay. Well, you frequently relate a story about your findings of geographic variation in terms of your children. And here are your children. Perhaps you'd introduce them to us.
Well, believe it or not, they are my children. And the beginning at the top, that's Mark, who now is close to 50, and he works with the criminal justice system in Vermont. My daughter lives in the house where we were living at that time, and she's a nurse practitioner. My son, Paul rather, is the second up on the ladder, is now a professor at Caltech, and David still and I still work together on practice variations, as you know.
That's great. Yeah. Well, and what was the story of how geographic variations might have affected your children?
Right. Well, it had nothing to do with sunflowers and being in front of the barn, but rather we lived at that time right on the boundary between 2 of the regional market areas that we were looking at in our data system, namely the Morrisville Stowe area and the Waterbury Montpelier area. And one of the most remarkable findings that we had in that was such great differences in the tonsillectomy rates. And I put these kids up on or put it this way, the story that I now tell about the latter scene here was that had my children lived in Morrisville, 3 out of 4 of them would have had their tonsils out by the time they got to be 15. In the Waterbury situation, only 1 would have.
Wow.
And since both my wife and I were physicians, we pretty well assured that none of them actually got a tonsillectomy.
Well, let's talk a little bit about Vermont. These are Vermont's hospital service areas. You're looking at a map of the state of Vermont that you published in Scientific American in 1982. And the small units are Vermont townships, and the larger units are Vermont hospital service areas, each of which has a hospital.
Right.
And these are the 1969 tonsillectomy rates in Vermont. Some areas were right about at the national average. Some were considerably above the national average, and 2 were more than 2 times the national average. Of course, there were also areas considerably below the national average, and in fact, there was one area that was less than half the national average. So the extremes were Morrisville, as you mentioned, which compared to Middlebury had 10 times as many tonsillectomies per capita. Now, you asked variants of this question again and again. You looked at hysterectomy, you looked at prostatectomy, you looked at cholecystectomy, and you looked at the rate of overall hospitalization itself, and you looked at the rate of physician visits. And in each case, you unearthed dramatic geographic variations in the utilization of medical services among apparently similar populations. You published these results in an article called Small Area Variations in Health Care Delivery in 1973. You did it in the journal Science. Why not a medical journal?
Well, Alan Gittleson and I, and Alan deserved a lot of credit for this work, tried the usual medical journals, but for some reason the message of variation did not hit a harmonious chord with the editors, and we would get sort of basically form rejection saying this is of no interest to the profession. That wasn't quite the way they said it, but it was the way I felt it anyway.
So they just weren't ready for the message?
Well, they weren't ready for it, that's for sure, and I don't think they got it, for one thing. Otherwise they would have probably tried to do something to capture it as a professional problem. So fortunately, Carr White and other colleagues of mine who did recognize the importance of this interceded with the editor of Science, which ordinarily doesn't publish this kind of work, and asked that they consider it. And fortunately for us, really fortunately for us, Science said yes.
Yeah, and I just want our viewers to have a sense of what you wrote in that article, and perhaps you would read this to us.
Right. Well, this is after looking at essentially the utter chaos in terms of procedure rates around Vermont. It wasn't just tonsillectomy; it was virtually everything we looked at. And we basically also were not able to show any relationship between mortality or need based on poverty and so forth. And so basically what I came up with, or Alan and I came up with, was this concept of the null hypothesis. We really don't know what's going on. Right. And this is what was captured in this quote, namely, given the magnitude of the variations, the possibility of too much medical care, and the intended likelihood of iatrogenic disease, that's physician-caused disease, is as strong as the possibility of not enough services and unintended morbidity and mortality.
Wow.
Yeah.
Too much medical care.
Too much.
Yeah, that might have been part of the explanations why the medical journal didn't take
I
it.
have a strong suspicion you're right on that. But
let's go back just a second to Morrisville, if I could. And you didn't stop there with noting that they had just had high rates. You actually went and talked to the docs in town. Tell us about that.
Well, Alan and I basically took the data to the Vermont Medical Society, which we had had some relationships with because we were interacting with them in terms of regionalization. But they hadn't expected this. And they were quite upset, I think it's fair to say. But also, as it turned out, they didn't put it under the cabbage tree and leave it there.
That's great.
They basically, unbeknownst to Alan and me, circulated the data among physicians throughout the state, And there were some pretty interesting changes.
That's great. Well, the Vermont work unearthed dramatic geographic variations in medical practice and made clear that there was a new problem for healthcare policymakers: too much medical care. And you found at least that some doctors wanted to fix it. In our next episode, we'll follow you to Maine.